My dear friends, Dr. R.P. Gupta, President, International College of Dentists, India, Sri Lanka and Nepal Section, and Indian Dental Association, Chandigarh State Branch, eminent speaker of the day, Dr. Raghupathia, fellows from ICD International Head Office, members of the Board of Regents of ICD Section 6, Executive Committee members of IIT Chandigarh State Branch, dear ICD Masters and Fellows, and dear colleagues from all across the world. I welcome you all to the second session of the certificate program on infection control and occupational safety in dental practice, being conducted by our fellow dear Dr. Raghupathia from USA, with the Authority on Infection Diseases Control in Dentistry. The program is initiated by the ICD International Head Office in collaboration with the ICD Section 6 and ID Chandigarh State Branch. Today, Dr. Pathaya will be talking on emerging diseases, epidemics and pandemics of the past and the present, and selection, use and misuse of germicides. I invite Dr. Mahesh Verma, Vice Chancellor, Indraprastha University, Delhi, and Chairman of Continuing Dental Education, ICD Section 6, to take the proceedings forward. Over to you, Dr. Mahesh Verma.
Thank you, Rajiv. Good evening, everybody. I'm sure everybody is eagerly waiting for Module 2, Session 2nd of the certificate program on certificate course, rather, on practical dental infection control and safety. Of course, as Rajiv said, being brought to you by International College of Dentists Head Office, along with International College of Dentists Section 6, which is India, Sri Lanka and Nepal section. While acknowledging the presence of Dr. R.P. Gupta, President, past President, Head Office, Dr. Rajesh Channa, Secretary General, Dr. Rajiv Chugh, and International Council, Dr. Anil Kohli. I can also see a lot of our other board members connected, Dr. Virmani, Dr. Hari Prakash, Dr. R.K. Bali, Dr. Sharad Kapoor, Dr. Puneet Batra, Dr. D.N. Kapoor, Dr. Meera Verma, and all the zonal regions, deputy zonal regions, and all those who are connected for this program. For those of you who missed the first session, I wish to inform you that this is a second session of 5 series, and the faculty, the chief faculty is Dr. Raghupathia, who's recently retired as a tenured professor from Department of Public Health Sciences, College of Dentistry, Dallas, Texas. And, as we all know, that he is his area of core competence has been public health, infection control, safety, OSHA, HIPAA guidelines, so on and so forth. And he's been very instrumental in crafting dental safety standards, which is being used globally, including India. And he's been a good researcher, very able reviewer, and also consultant to almost 25 industries. So it is not just, theory or, information, but it is also the voice of industry. What is that which works and what is that which doesn't work. Currently, he's, as I said, that he's bringing this program as a scientific director of dental safety of ICD head office as a part of Train the Trainers program, and for us, for that, ICD Section 6 fellows, would be the fellows as well as other profession colleagues will be benefited. And, as I said last time, that during this Corona times, I think this information is like a Sanjeevani booty, as we all know that infection control is like a lifeline of a practice, and most of us think the information is very static, but it is dynamic, it changes, concept changes, new and new things come. And today's session, he's going to talk about what are the emerging diseases and what has been the epidemics and pandemics in the past and what we are going through, and also how do we choose the germicides and all those drugs, and how do we use them, and how do we misuse them. Before I invite him, let us little recap what we did last time. And last time we talked about how practical infection control is important for a dental team, and Dr. Raghu gave us a little bit of history of epidemics and pandemics, and what is the rationale or infectious diseases. He also talked about a little bit about what are the different routes of transmission. Is it contact, inhalation, fomites, or is it through skin, percutaneous? He also talked a little bit about standards, how the standards came about, and some potent statements which he made in the first module was treat all the patients as potentially infectious. That means every patient coming to you, you have to think is a potentially case of a potential infection. He also said that education through social media and professional group is entirely different. So many a times, we go by what is in vogue and what is being circulated through social media. And he said one more thing, that the precautions during epidemic and non-epidemic is precautions are totally different. It is not the same. And let us not mimic, but practice standard with knowledge. Many a time we just feign or we just act and we just mimic, but I think we got to understand it and we got to apply it. He also talked about, what are the basic control measures which are to be followed, and what are the infections which are which can impact dentistry, and it's their transmission. He a little bit talked about hepatitis B, talked about HIV/AIDS, and he talked about tuberculosis, SARS, influenza, and also touched about a little bit about COVID. So at this juncture, let me invite Dr. Raghu. But before that, we have one or two senior members, senior colleagues here, Dr. R.K. Bali, Dr. Hari Prakash, if they want to just speak for a minute only, because we are running late and we only have 1 hour, but if they want to say for a minute or so, they can say. Please. Anybody wants to make a little comment, because I think we did not invite them last time. So, Dr. Bali, Dr. Hari Prakash, it's okay. So, Raghu, please go ahead.
Sure, sir. Thank you. Thank you, Dr. Verma. Thank you, both the Dr. Guptas, Dr. R.P. Gupta and Arpit. And hold on 1 second. I will. Hold on just 1 minute, please. I'm getting a little bit of a, yeah.
May I request that everybody else, please, mute yourself, because so that there is no disturbance to the speaker.
Mahesh, can you see the screen now? Mahesh?
We can see that, but yeah, we want a module 2. This is
Yes.
module 3.
No, this
That's
is
okay.
It's lecture 2. Yeah, module 3, lecture 2.
Okay,
I mean,
that's fine. That's
yeah.
Session 2. We want session 2.
Yeah. Okay. I think I have to get that old retired professor mind back in. Sorry about that. Anyway, thank you so much. To recap, last time we talked about common infectious diseases. We talked about concepts. We talked about the history. Today, let's talk about the devices we use to protect ourselves and to control cross-contamination, in a dental clinic. I will not purely concentrate on COVID. Most of my lectures have been addressing additional or transmission-based precautions, since SARS in 2003, H1N1 in 2009. So the same principles have been applied, the same devices by much advanced clinics in private practices have been using it since 2003. But if there are any particular questions you have about COVID too, we can talk about that after this module. Okay. So we talk a little bit about germicides. So um, what I normally talk about is it's not the FDA or the EPA. Each country, each region has got their own governmental clearance of medical devices. A device can be, a machine. A device can be a germicide or a disinfectant or a sterilant. And there are normally two sections of the federal government or the central governments in most places. One that deals with items that come in contact with humans and put humans at risk of side effects if you're in contact with certain germicides. The other um, section would deal with certain germicides that could be an environmental hazard when it's allowed to flow into the the drinking waterways, the rivers, the watersheds, and also the land. So, what basically, in a practical manner, let's talk about this. Antiseptics and sterilants come in contact with humans. Okay? Antiseptics commonly used in dentistry are mouthwash, swabs, paints, soaps, alcohol swabs to, what you call clean the skin before we apply we inject medications. And some of these can range from alcohol to chlorhexidine to quaternary ammonium compounds. Okay? Then you have immersion sterilants and high-level disinfectants. In dentistry, most of our devices, reusable devices or instruments, can be sterilized through autoclaving, steam under pressure. It is a modified pressure cooker, if you look at it, any autoclave. And the other side, the sad part is we still are using devices that cannot withstand a heat sterilization. So we have to sterilize it before we put it into a patient's mouth. So we have chemicals which we immerse them into. Some of these chemicals are aldehydes like glutaraldehyde, which is one of the oldest immersion sterilants. Then you have orthothalyldehyde, which is OPA. Then you have certain acids such as peracetic acid, hydrogen peroxide, and the combination of peracetic acid and hydrogen peroxide. Then the most commonly used ones in most countries are halogen compounds, such as bleach, sodium hypochlorite, bromine, and fluorine. Okay? All of these, when we immerse the instruments in them for a given time to sterilize them, we have to rinse them out with sterile water if they're going to be sterile instruments, like critical instruments. If they're non-critical instruments, you could rinse them out with clean water. Okay? Now, the surface disinfectants, on the other hand, those that are very extensively used in medicine and dentistry, they fall under the guidelines in the US under the Environmental Protection Agency. But in India, you have the Medical Devices Act and so on. And Europe, you have the CE clearance and so on. But bottom line is, these devices do not normally come in contact with human skin, because whenever we are using these devices to disinfect a surface or so on, we actually wear personal protective equipment, such as gloves, masks, eyes, and a gown, depending on what is required by the chemical to avoid an exposure. Okay. Now, the immersion sterilants, on the other hand, they can kill bacterial endospores, but the surface disinfectants, the sprays we use in the clinic, need not kill bacterial endospores, but they will kill spore formers. They will kill vegetative microbes. They'll kill viruses. They'll kill fungi. So the most common ones we use are halogens, phenols, and quaternary ammonia compounds. Under the halogens, one of the most powerful one is chlorine dioxide. Then you have sodium dichloroisocyanurate. Then you have hypochlorous acid or an anolyte. Then you have iodophores. The next one we have are phenolics. It could be bisphenols, trifenols. Then we have things like Dettol, parachloromethaxylenol, but Dettol is not cleared in most advanced countries, medically advanced countries, as a surface disinfectant. It's only cleared as an antiseptic. You know. Then we have dichloromethaxylenol, which is again similar to same thing as Dettol. The weakest ones are quaternary ammonia compounds. Okay, they may or may not contain alcohol. Okay? Most of these, if you think of quaternary ammonia compounds, I classify them as, in my classification, I'm not a microbiologist, but given what we use Windex to clean glass. That is a quaternary ammonia compound. We use certain cleaning agents, the sprays in the kitchen, like 409. Those are all quaternary ammonia compounds. In the past, they were all classified as low-level disinfectants, which were not to be used medically. But certain industry members, they went ahead and modified the formulation a little by adding alcohol and other surfactants, and they got it cleared with a TB kill claim. Okay? But in my opinion, there are better compounds than that. So let's talk a little bit about antimicrobial hand soaps for general dentistry. For oral surgery, they use surgical scrubs, which have, iodine scrubs and so on. But for general dentistry, we use chlorhexidine. For the mouthwashes, we use 0.2%, but for a hand wash, we use 2% chlorhexidine-based soaps. They're the best. Yep. Then you have the iodine surgical scrubs. Then you have chlorhexidine 4%, which is used for as a surgical scrub before endosseous surgery. Please understand that we in dentistry are now at the juncture where most general dentists are doing a lot of endosseous work, such as placing implants. One of the things which oral surgeons and many periodontists used to do for all the endosseous surgeries was to do a surgical scrub with either iodine-based surgical scrub or with a 4% chlorhexidine gluconate. What I would, suggest for us when we are doing any implant surgeries, when we are doing third molar extractions, when we are opening up the bone, we must think about at least a level of a surgical scrub, using a higher level germicide. Then after using the soap to wash your hands, that is when we can use an alcohol spray on our hands when your hands are already clean, to make it cleaner. That's it. The alcohol sprays without washing your hands, they are a non-entity in my opinion, because I have done many studies where we found that alcohol sticks dirt and the dead skin cells to your skin. Okay? So that itself is a contaminant during surgeries. Okay? So the best thing to do in the medical area, when I say medical, I'm talking dental too, is to use the alcohol sprays and alcohol gels after a hand wash. That prolongs your cleanliness of your hands. Okay? Then let's talk a little bit about mouthwashes. See, before COVID happened, at least in the US, all the patients who walk into the dental clinic are given a mouthwash. Okay, it is called a pre-procedural mouth rinse. I've been involved with chlorhexidine gluconate, from the mid 90s, early 90s to mid 90s, and prior to that, it was in India. We did use chlorhexidine gluconate for patients with periodontal disease. But here, when I came here, there was already a ready-to-use device with 0.12% chlorhexidine gluconate, which we gave as a pre-procedural mouth rinse. The purpose of this was to reduce the microbial load in the mouth for anywhere between 40 minutes to 90 minutes if you use chlorhexidine. Okay. The next ones would be like items like scopes or sanguinarine or Listerine, the polyphenols and phenols, which are there in the other compounds. They are one step below chlorhexidine level. Okay? They would keep your mouth clean for about 30 minutes to 40 minutes, good enough for one procedure, so that your exposure to the microbes of the oral cavity is reduced considerably. But what happened during COVID was people started looking at, as Dr. Verma said, social media, education through social media, getting a DDS through social media, continuing education through social media is a non sequitur. I find that more damaging because it is contrary to actual evidence-based education. There was one paper which said, oh, you can use povidone iodine, and people started using povidone iodine. Then one person said, oh, you can use hydrogen peroxide. Yeah, hydrogen peroxide was a common thing among households in India. I used to get calls at all odd hours asking what is the hydrogen peroxide concentration one can use. So I'd say the minimum dilution, the maximum concentration you can have is go to the store, buy a hydrogen peroxide, take 2 parts of water, one part of hydrogen peroxide. Oh, does this kill COVID? Yeah, it does kill COVID. So does club soda. Okay. Or Coca-Cola kills COVID. COVID is, when you come to think about it, it's a lipophilic virus. Most lipophilic viruses like HIV, influenza, COVID, all of them die with the weakest of the germicides. Oh, will chlorhexidine kill it? I said, sure it will. So anyway, there are so many different mouthwashes we use. Use any approved mouthwash in a patient's mouth. Now, will it prevent us from getting COVID? No, it will not. They are not picking the origin and the presence of the viruses in the body. They are just talking about a germicide. The place where the COVID virus multiplies and resides is in your upper respiratory tract. It is in your oropharynx and your nasopharynx. Most of these mouthwashes will only clean your oral cavity and the outer part of your oropharynx. Okay. So just use any mouthwash. That's good enough. And don't think that you're not going to get COVID just because you use the mouthwash. So it's like applying a Band-Aid when it comes to COVID. Then let's talk a little bit about sterilants and high-level disinfectants. Take, for example, Cidex is glutaraldehyde. It is 3.4% glutaraldehyde. Okay. And it's got about 20% alcohol in it. Okay. For sterilization, you have your instruments that are cleaned before you immerse it into the glutaraldehyde. This one, Cidex, let's say, for 6 hours at 25 degrees Celsius. If it is colder, if it's 22 or 20 degrees Celsius, it will have to go to 8 hours for activity. Okay. These are for surgical instruments that cannot withstand heat sterilization. Since most of the devices, almost every device we use, which are critical items, are either single-use disposable or heat stable, we do not in the US use glutaraldehyde for most surgical instruments. Where we use glutaraldehyde is when you're using the older style intraoral mirrors for photography and certain heat labile cheek retractors. So for that, you do not need a complete sterilization cycle. You can do a shorter cycle with the same concentration of an immersion sterilant for about 5 minutes, okay, at 25 degrees, and then you rinse it out with clean water. And then you can keep it in a clean container and use it on the next patient. So the chemicals commonly used are glutaraldehyde, Cidex OPA or phthalaldehydes. You can use peracetic acid. You can use hydrogen peroxide. And you can also use hypochlorous acid if it is a chemically generated hypochlorous acid, not electrochemically. Because electrochemically, most of the electrochemically generated for what you call tabletop devices, those things generate only up to 200 to 500 parts per million at best of hypochlorous acid or anolite. Okay? The industrial ones can generate a lot more than that. So, so these are some of the things you have to think about and when you're using germicides. Now, the most amount of misunderstanding and abuse comes when you choose a surface disinfectant, the spray. I still come across people here in the US who think that alcohol, pure isopropyl alcohol, is a good surface disinfectant. No, it is not. It is not cleared as a surface disinfectant. Okay? So, because there are many qualifications a surface disinfectant has to have to be cleared as a device to be used in medicine and dentistry. Number one, it should be an intermediate level disinfectant. That means it is one step below the high level disinfectants or sterilants. So this is an intermediate level disinfectant. To achieve that claim, it should kill tuberculosis bacillus. Now, I'm not talking of tuberculosis bacillus as a disease. I'm talking of tuberculosis bacillus as Mycobacterium tuberculosis, Mycobacterium as a marker organism. Okay, so it must have a TB kill claim. Then it should also have a kill claim of hospital as a hospital disinfectant. And it should kill 3 marker organisms that are commonly found in hospital infections or nosocomial infections, such as Pseudomonas aeruginosa, Salmonella typhimurium, Staphylococcus aureus. Okay? These 3 are very tough organisms to kill, so it should have those organisms claim as well to be a hospital disinfectant. The next is it has to kill fungi. Okay? The most important and abused ones by dental industry who wants to sell a disinfectant is when it comes to a virus kill claim. So there are 2 types of viruses it has to be tested against, the lipophilic viruses and the hydrophilic viruses. The hydrophilic viruses are very tough organisms. They don't have a fat coating. The fat coating protects normally the lipophilic viruses. So if you disturb the fat coating, the cover, the lipophilic viruses tend to denature very easily. Okay, so you change the pH, either make it a little more alkaline or a little more acidic, you can kill lipophilic viruses. Lipophilic viruses are the most common ones: HIV, influenza, today COVID. Yeah. So if you look at any new disinfectant labeling, all these fellows who work with the industry, they get these claims because they are diseases with a stigma. Okay, either as with a social stigma, or it is an epidemic that is ravaging countries. So they advertise on the label itself, it kills HIV, the virus that causes AIDS. It kills COVID, SARS coronavirus 2, and so on. Okay, they play upon your emotions. I'm not worried about that. I'm worried about the hydrophilic viruses, the tougher ones to kill. If you look at the disinfectant, it should kill rotavirus and poliovirus. Those are the two toughest viruses to kill. If it kills that, it pretty much kills most of the other things. Becomes an easy clearance for them. Okay. So what I'm saying is most of these labelings are influenced a lot by marketing and sales rather than the quality of the disinfectant. Okay. Then it should be compatible with all the surfaces we disinfect in the clinic. Now, the vehicle that carries the active ingredient should be water-based, because water-based disinfectants stay on the surface long enough for the TB kill time, for the hospital disinfectant kill time, for the fungal kill time, and the viral kill time. Okay? The alcohol-based ones, if it has got more than 70% alcohol, it evaporates and it's not good. It sticks the dirt onto the surfaces. Okay? So sprays and wipes. Now everybody is going to wipes, pre-soaked wipes. Please remember, pre-soaked wipes are made from plastic-like material which does not biodegrade. I still tell people, use a spray bottle and a paper towel. Wipe the surface and then throw the paper towel away, it will biodegrade. Now, among the surface disinfectants, the best ones you have, you can't use chlorine dioxide, you can't use bleach. Yeah, if you use those, sure, your dental unit, your surfaces, all of them will get bleached or corroded. In 1997, I did a very large study on electrochemically activated water, or brine. And that the output of that chemical from the device was, we called it anolyte, because we took it from the anode aspect of the electrodes. Okay, they're basically a range of chemicals. They go from acidic to very basic, depending on where you collect your sample within that electrochemical cell. Okay, the one we found which was very powerful in killing microorganisms was called the anolyte. And it also was very compatible with the surfaces because its pH was around 6. Okay. We called it anolyte. Today, everybody uses it and they call it hypochlorous acid. Then there are chemically generated hypochlorous acids. Okay. Those, they can generate up to 5,000 parts per million of hypochlorous acid, yet maintaining the same pH of around 6, which is not damaging, to the other materials. So we use chemically generated hypochlorous acid in the clinic these days. I mean, it's really picked up in the US, and I feel that's the only chemical which has got a clearance as a surface disinfectant and to remove biofilms in dental unit water systems as well. Okay? The other ones are accelerated hydrogen peroxide. This is at 0.5% accelerated hydrogen peroxide concentration. It's a good disinfectant. Its pH is good. It's not too acidic, not too basic. Okay. Then we have the ones which are electrochemically generated. The commercially available ones for the dental clinic, those are normally considered low-level disinfectants, as far as I'm concerned, and as far as most of the educated regulators are concerned. They normally generate up to 200 parts per million of hypochlorous acid. Okay. They are good for using as sprays, but they still can do a fairly decent cleaning, okay, of surfaces and have a decent kill claim, but they're not anywhere close to the chemically generated ones. Until and unless if it is a electrochemical cell, which can generate a much higher higher concentration of it. Now, when you disinfect a surface, there are two steps involved in it. One is the sanitization step, that is to clean the surface. The other step, the next step, is the disinfection step. Okay. So when you're spraying onto a surface and wiping it down for the first time, you're sanitizing the surface with the disinfectant. Remember, all disinfectants come with soaps built into them, so they are good cleaners as well. So the first step is you spray and you wipe. That is the sanitization step. The next step is to spray the disinfectant and leave it for a minimum amount as needed to kill TB on their TB kill claim. Some will say we have a TB kill claim of 5 minutes. In that case, you'll have to leave the surface disinfectant on the surface for 5 minutes. Okay. Then you can wipe off. After the 5 minutes, you can wipe off the excess which is there. Now, there's another aspect of it which comes into play. In most countries I've been to, not the Western Europe, not the US, and if I go to Central America, if I go to parts of Asia, if I go to parts of Arabia and so on, what I found is most countries are trying to mimic what is cleared in the US. And what I'm seeing is a lot of the quaternary ammonia compounds are being sold out there. And mind you, they're very weak compounds. Countries like Canada, countries, a few European countries, they do not consider quaternary ammonia compounds like cavicide or Discide or those things as intermediate level disinfectants. They consider them as low level disinfectants. So what I would suggest is try and see if you can get at least a dual phenolic, a bisphenol, dual synthetic phenolic or a triphenolic. If not, get a hypochlorous acid, chemically generated ones. And it can be manufactured in India as well, and they are cheap actually to manufacture and sell, except in most other advanced countries, medically advanced countries, they sell it at a very high price because it's the new kid on the block. Now, let's get back to universal precautions and transmission-based precautions. I'm talking of all the airborne epidemics we've faced, the SARS, the H1 influenza, MERS, and so on. They are spread through air predominantly. Okay? Many people in close contacts in a closed setting, there's a better chance of disease spread. So where to use these surface disinfectants? We need to use them on high touch surfaces, common surfaces, including doorknobs, door handles. In the waiting room, when the patient comes and sits, don't have a sofa out there which you cannot disinfect. Have the cheap plastic chairs where they can sit, so can wipe down the chairs after the patient leaves. You don't know where the patient's hands have been, whether the guy's touched his lips, nose, and then they'll be holding on to the chair. Same thing with the high touch surfaces, the clinic side. Okay. Now, apart from that, you have to improve the air circulation with purer air within your facility. Recirculating. See, when you're outside doing a camp, you're not indoors, you're outside and the air is abundant. Okay, it's infinite. It's not enclosed. But when you're inside a building, there are X number of people breathing about 70 liters of air per minute. Okay. And then there is some amount of air evacuation in the building and recirculation in the building given air conditioning. So you have to factor all those things into the spread of bioaerosols. And that is the disease process which COVID spreads through. So you have to bump it up with using recirculation devices, either single unit recirculation devices, which are present in each operatory, with the HEPA filter, and if possible, UV light, but a plain HEPA filter device, which can recirculate the air within that room for, about, what you call 4 to 5 times a minute, would still be a great help in reduction of airborne diseases. Okay. Now, disinfection of impressions, let's talk about it. You rinse the impression out, shake off the water, spray the impression with the disinfectant, wait for the TB kill time, then rinse out the impression with water, and then you're ready to pour your cast. If you're using digital scanners for impressions, there are 2 parts of the scanner. One which goes into the patient's mouth, this part, and then the other one is the handle. Okay. The handle part can be disinfected with a surface disinfectant. But this one, the cover can go into an autoclave. Then inside this, there is a glass prism, which is there that needs to be wiped out with an optical grade a disinfectant or at least a sanitizing thing, just like what you spray onto your glasses and wipe it down with a microfiber cloth. That you can do so that the image is not distorted. Okay. As far as cleaning capabilities are concerned, quaternary ammonia compounds, I told that the worst disinfectants, they are very good cleaners though. Okay. Then you have phenolics, then you have PCMX, chlorines, and then iodophores. Alcohol-based ones are not, vehicle-based ones are not good cleaners. They tend to fix the bioburden. Okay, so try to get one which is water-based. Then you have your evacuation hoses, your saliva ejector and your high volume evacuation hoses. Those must be cleaned at least once a week with a quaternary ammonia compound based thing or an enzymatic compound, because there tends to be suck back from that into the patient's mouth occasionally. Okay, you don't want that to happen. Now, there are many agents which we use to clean water lines, but we'll deal with that topic later. Let's talk about hand washing. Okay. So, as I said, try to use at least a 2% chlorhexidine based soap, or you can use a Dettol based soap or a PCMX soap. Okay. PCMX is inexpensive. It is widely available in India and most of the other countries. So you can use that. Okay. Now, before you wash your hands, take off your watch, take off your ring, okay, examine your hands, okay, to see if you have any cuts and bruises. If there are any cuts and bruises, you'll have to apply a first aid for that. Okay. If you don't, then you can go ahead and then under warm running water, wet your hands, apply your soap, and people say, oh, at least for 30 seconds. No, do it for a minute at least. Okay, till your hand feels squeaky clean. Apply the soap, keep rubbing the soap, for at least about a minute, and then start rinsing it with warm water. and rub your hands while you're rinsing so that the soap along with the dirt and the dead skin comes off. Dry your hands with a paper towel, disposable paper towel. Don't use a reusable cotton towels. Okay. They spread germs from one surface to the other like crazy. They're great in cross contamination. They help cross contamination rather than prevent it. Okay. Once your hands are nice and dry, then go ahead and wear your gloves. Now, if you have cuts and bruises, in the past I used to say, yeah, apply some medicament to it and then apply a band-aid and then wear a finger cot. And on top of the finger cot, you go ahead and wear your gloves. But today you have items like New Skin or Next Care, which is an acrylic-based paint and dressing. You apply it, it's like nail polish. Apply it, and within minutes, the thing dries out, and that will stay on your skin for almost 3 to 4 days. Okay, so you won't have any bloodborne pathogens going through that cut into your skin. Okay. Once you take your gloves off, immediately wash your hands. Do it for at least 30 seconds. The same process. Do it for 30 seconds. The reason you need to do this is when you wear your gloves for about 40 minutes, for one session, let's say, the microbes, your commensals, which are there, the common residing microbes on your skin, tend to multiply like crazy. Okay. Think about it. It'll be nice and warm and moist, and then the mitotic activity goes on really fast. If you don't wash your hands after you take your gloves off, sooner or later you'll develop a skin condition or some dermatitis or so. So you don't want that on your hands. Okay? How do you take your gloves off? With the gloved hand, grab the outer surface of the glove on the other hand, peel it off like skin. Okay? Dump it. Then with the ungloved hand, sneak it under the glove of the gloved hand and then peel it off, and then you can throw it out. Okay? So we did a study looking at comparing different types of germicides in hand soaps. And guess what we found? We found it is not purely the chemical, the germicide, which is there, but it's probably the soap, the cleaning capacity of the soap, which reduces the microbial load on your hands. We found, I'd been to one of the IADR meetings in Wales a few years ago, and I picked up a small bar soap in the hotel. I just bring them home sometimes for my guest room. But I said, let me try this thing out. And I used that in that study, and I found it showing better control measures than your lower microbial load on your hands than even chlorhexidine 2%. Okay, so it all depends. Glycerin-based soaps are good. Okay? Now, what I find a lot being abused are the antiseptics or the gels, hand gels, alcohol-based gels, or alcohol-based sprays. The gels and sprays tend to stick onto the dirt onto your hands. So what I tell people is take twice the amount of gel and then apply it onto your hand, take a paper towel and wipe your hands with the paper towel so it removes the dirt. Or you can go for towelettes, which are pre-soaked in germicides. Okay? End of every session, once in the afternoon, once in the evening, apply a moisturizing agent onto your hand. Okay, when you're taking a break. That actually helps preserve the skin and makes the skin healthy. Now, let's talk a little bit about PPE. PPE and barriers. I put them under the broad classification as barriers. Barriers that are used on the humans to avoid contamination from splash, spatter, dust and mist. Those are called PPE. Then the ones that control the surfaces from being contaminated are called surface barriers. They protect employees from bloodborne pathogens, chemical hazards, dust and mist. Okay? And recently, we've all been introduced to N95 or KN95, N100, P100. Most of us are using that now, but I used to use that when I used to actually go see HIV patients who were actually in a TB ward, a TB room, which is a negative air pressure room. Okay? This is during the early 90s when HIV was the pandemic of the time. And they also had the comorbidities like TB. If you had to go and see a TB patient in a negative air pressure room, you have to go ahead and wear an N95 mask at least. Okay? So I was exposed to those things way back in time because it was needed. Later, I found out that many of these TB conditions were multi-drug resistant tuberculosis. But luckily, I haven't picked up TB yet. I can say that. Then you have different kinds of shields on different devices and so on. Okay? Now, think about the level of PPE I told you. There are two levels, right? Full PPE and limited PPE. Full PPE is when you are going to be generating splash or spatter. Okay? When you generate splash or spatter, you should have eye protection. You should wear a mask, at least a surgical mask. Then you should have gown, and then you should have gloves. Okay? That is to control splash or spatter. So whenever you lift a 3-way syringe, an ultrasonic scaler, or a handpiece, we're going to be generating bioaerosols. You need to wear full PPE. Suppose you're going to remove just a suture. All you need is a clean pair of gloves, okay, and two sterile instruments. One is the scissors and one is the tweezer to get the suture off. That's about it. Or when you're doing X-rays, taking X-rays in radiology, all you need is a pair of gloves. You're not going to be exposed to splash or spatter out there. Okay? Now, during conditions like SARS-CoV-2 or COVID, you need to wear a positive, N95 mask, a positive air pressure respirator, okay, one or the other. That helps control the breathing of these airborne particles. It doesn't prevent, it'll control. Okay, remember, control is the word. It's just like saying, oh, I've seen so many people who've got a vaccination for for COVID, but they still picked up the disease, or they're exposed to the disease and then they had fever. Sure, not everybody who's immunized is actually protected. It will reduce the level of the disease, but it will not protect them when they're exposed. Same way, gloves, if you put it under a scanning electron microscope, they have microporosities where viruses can go through. But it is preventing gross contamination. Okay? So the common, let's talk a little bit about the common PPE. Normal conditions, I wear mask, gown, gloves. Okay. If you're doing major hygiene procedures, I used to tell them wear a face shield, and then you wear your mask. If you're going to be wearing prescription glasses, you can wear a side shield. And I told you the difference between minimal PPE and full PPE. Okay? Now, one of the things which is most misunderstood is disease transmission of airborne disease transmission in a close quarters or close setting. Okay? Whenever you sneeze, cough, or breathe, you have two different sized particles that come out. Particle sizes that are larger than 5 microns in diameter are heavier particles. They are more moisture laden. They tend to settle down onto a surface, be it 4 feet, be it 6 feet, be it 10 feet. Particles that are smaller than 5 microns in diameter tend to be lighter, drier, and they can be airborne and they can stay in the air for hours. They're called bioaerosols. When you cough, the particulate matter can be, the heavier ones can be spread all the way to about 4 to 6 feet. But when you sneeze, since it goes through a smaller diameter tubule, it can go up to 18 to 20 feet. There are studies done by the Japanese and then by an Indian dentist, a dentist of Indian origin in the UK, Vasant Vadagama. They have been looking at the spread of airborne particles. So when COVID came, they said start using N95 masks. To qualify to use an N95 mask, you should have something called a face fit. You cannot have a beard. Okay. Not everybody can get a face fit done for the mask. About 10 to 15% of the people, whatever type of N95 mask you try to put, different size, different shape, it will not fit certain people. Okay. And another thing is, whenever you lose 20 pounds of weight or gain 20 pounds of weight, you'll have to go for a refit test. Okay. And these masks are very difficult to breathe through. I can tell you that. What I used to use was the N100 or P100 masks, and those were actually pretty good. They had two filters, okay, disposable filters. We used to take them off at the end of each day at best. The rest of the mask, you can wipe it down with a surface disinfectant between patients. And it has got a better seal. You don't have to go for a face fit for this because it's got a huge thick silicone bead which goes around the surface of the inner facial aspect of the mask, which will sit better. Then you have the positive air pressure respirators, which actually blows in air through HEPA filters. It's got a battery pack. It's got a pump. It sucks in air from the ambient air from the room, pushes it through a HEPA filter, and then it makes the air circulate out here, and then it's pushed out through another HEPA filter out into the ambient air. So what happens is you have fresh air coming through, and its breathing is easy. There's no fogging, and you can use loops as well in some of these. Okay? The other ones which I've always said, there is a certain segment of the dental population out here in America, the dentists, who call themselves holistic dentists. Okay, people, say that they believe in overkill. No, they were not. They were more worried about, amalgam. They were more worried about mercury in the air. They were worried about certain chemicals and disinfection byproducts and so on. They used to use air recirculation devices way back, even before SARS, before 2003. Okay. They used HEPA filters to filter out the thing, and then those machines were running throughout the work time, 8 hours a day. They had one in each operatory. Okay. They also had this device, which, it's like a tulip, which comes all the way up to your face. Either a device like this or a device like this, which comes and sucks out all the air as the patient is breathing out, or whether they cough or they sneeze, it sucks it out. Now, this they used in addition to using a rubber dam and a high volume evacuator, or an intraoral device like the leaf or so on. So there was a combination of items that they could use. Okay? But only recently have I seen, people in other countries now saying, oh yeah, we got to do this because of COVID. No, it is not because of COVID. These people used it way back in time because of disinfection byproducts. Okay? Then, if you have a larger building, yesterday, actually day before yesterday, I drove back from South Texas. It's almost about 700 miles away from my house. Went to a dental office to actually inspect the office, and what the dentist was using in the HVAC system, the the air conditioning system of the whole building, centralized thing, he had these lights which were already inset into a chamber where air circulated through this chamber. This is a very high intensity light, and they replace this light every so often. Plus, they have static creating devices which tend to pull particulate matter onto a filter. Okay, so the quality of air within that building itself was fantastic. It's like day and night. Okay, so there are ones which you can introduce into to control bioaerosols in your building. Hospitals use that quite a bit. Then, these are the options. During normal times, you could use a level 1 to level 3 surgical mask, a shield or protective eyewear. Then during COVID time, you can use the same shield as a protection, and then you can use an N95 or a KN95 after a fit test. Then if you're using loops, you can also get a thing with a sleeve for the loop light to come out. Now, as I said, 10% of the subjects fail a fit test right from get-go. To get a fit test done, it's very difficult. Just wearing a mask, which you can N95, which you can breathe through, and if you're breathing through very easily, then it's not doing its filtration work. So here are some of the videos you can actually go through sometime when you have time to view them and understand what goes through a fit test, what is a HEPA filtration thing, and so on. Okay, taking off a respirator, how do you decontaminate respirators, and so on. Okay. Let's not worry about these. These are all things. Now, light. All of us use composites these days, right? These are not self-curing composites. They are light-cured composites. The lights we use to cure these composites, the wavelength is anywhere between 380 to 530 nanometers. They're very short wavelength, high penetration light. They're excellent in curing composites. Of course, they may cause shrinkage and so on and so forth, but don't worry about that part. The same light, if you hold it 6 centimeters away from your eyes for about 6 to 10 seconds, it can create macular degeneration immediately. I see people using these lights without using protective eyewear. Okay. So if you're going to be using curing lights, get 3 of these protective eyewear, one for you as an operator, one for the assistant, and one for the patient, so that you can freely use these curing lights without worry. Okay. Now, people have started using loops. They say, oh, how can I use that with loops on? Well, now there are loop inserts with these things, between your eye and the loop. You can actually put these inserts in and take it off once you're done. Okay. The things which they sell like paddles and small little shields with the orange shields, those are useless, I feel, because they do not absolutely control or prevent the light from bouncing off other surfaces and still damaging your eyes. If you're going to be doing lasers, using lasers, any type of a laser, hard tissue, soft tissue, mixed lasers, even the CO2 lasers, all those things, you got to use protective eyewear for that particular wavelength. Surface barriers. Surface barriers are to be used in between patients only when you cannot disinfect the surface. I normally tell people don't use too much of surface barriers. Use your surface disinfectants and disinfect the surface. Once the disinfection process is done, then you seat the patient, for care. Okay. So, but what I've seen is people say that, oh, it is much easier to use the surface barriers instead of disinfectants. So they keep changing surface barriers between patients. Please remember, those plastics are not picked up by any recirculation companies in the world. They go to the landfill. They don't recycle these plastic barriers. Okay. Now, there are preformed barriers, and then there is generic barriers. If you're using barriers, it doesn't matter to me whether you use preformed or generic. You got lots more money, go for the preformed ones. If you don't want to waste money, you can use the generic food wrap, So the light hands, electrical switches, high volume evacuator hoses, slow speed handpiece hose, air water syringe hose, headrests and handrests. Those are the common areas around the chair which you tend to barrier. Okay. Most of these can be wiped down with a surface disinfectant, and I'd advise that because you can never ever get rid of these barriers from the landfills. Okay. There's another barrier which you have is a bib. The bib is actually an absorbent material on the front, and the back it has got a cellulose-based plasticky material, which will control the flow of wet contaminants onto any surface. They are okay to use. They are biodegradable. Okay? So that is about barriers. So try to minimize the use of barriers as much as possible, and you'll be fine. And then there are electrical switches, which are what you call controlled by a electro cell, where you swipe your hand past the cell, it'll kind of turn on or turn off the lights and so on. Okay? Now, here is one area we've all moved into digital dentistry, quite a bit of devices, computer devices we use. If you're going to be using a mouse, don't try and get this type of a mouse, because for that you'll have to put a barrier and you can't still roll the mouse easily. Try and get a mouse which has got a silicone coating cover, which you can disinfect. You can't disinfect this particular keyboard, okay? But you can only barrier those keyboards. So there are options. There are preformed reusable silicone barriers which go onto a keyboard. Try and find those things, you should be available. Then there are keyboards made from silicone itself, but these are not good. It's very hard to type your stuff onto them. So that is about germicides and barriers. Okay. Any questions? I open it up to the people to ask questions now, because last time we didn't have much time to talk about the topic we spoke on last time. So I open it up to the
Raghu,
group to ask me. Yes, sir.
There have been some questions.
Okay.
Divyani says, what is meant by a negative pressure area?
Pardon?
So I think what do you mean by a negative pressure area? Because you did mention about this in your, you did mention that olden time. No. When you were looking at patients which were HIV, and
Correct.
even tuberculosis, you were going to an area, going to the clinic which has a negative pressure. So can you explain, Devyani, what to know?
Yeah. Yes. So you remember one day you introduced me to the head of the medical college in Maids, at Maids.
Yeah, that's right.
Right. They have the tuberculosis wing out there, where they said that they were seeing TB patients with active TB, multi-drug resistant TB, and extremely drug resistant TB. Okay.
That's right.
Right. Most of these patients are placed in a ward, at least in the US and a few other countries. The air actually flows through into that room through a HEPA filter, because they have active suction within the rooms. Like, in the sense, it is negative air. It is not ambient air, but air actually comes in from outside, and that air is also pushed out through a filtration system. Okay. So if you're walking in the corridor of the hallway, the air is ambient air. But once you walk into this room, there is negative air, because they pump out air from that room actively into the atmosphere outside of the building through a HEPA filter, so that it doesn't infect other people. It doesn't infect other patients who are there in the rest of the hospital. Those are the negative air pressure rooms. And they are a standard for in any of the infectious diseases wards you go through. There will be a certain section of that hospital or the clinic which will have negative air pressure rooms, so that you don't spread that to the rest of the people, through bioaerosols.
Many of the operating room or operation theater also have a negative pressure.
Correct. They do. That is because, and for the operating rooms, they also have the air coming in, which is also HEPA filtered air. And going out also, it has to be HEPA filtered. So that's why dental treatment rooms are nothing. It's just like a clean kitchen,
Yeah,
for general dentistry. Now, whenever you come across a patient who's got tuberculosis, or you suspect a patient who may have TB, when you can send them to a TB center to be tested for TB, and if they are, they either have to go into quarantine if they are positive for active TB. But if those people have a dental emergency, like this is what used to happen. The patients were already HIV seropositive, the ones I used to see, because I used to go through on the weekly grand rounds. And then what happened was a lot of those people had dental problems because they had necrotizing ulcerative periodontitis with loose teeth, and those teeth had to be extracted. So the group used to tell me, why don't you go back to the school, which was across the hallway. It was a separate building, but they always were connected. Pick up your surgical kit, you come on here, wear your respirator, and work on the patient, get the tooth out. At least you're alleviating the problem. Now, if a TB patient comes into your clinic, and into your general dental clinic, you can't see them. You can't be constantly exposed to them doing the procedure. So what we tell them is we send them to a tertiary medical center, which has a negative air pressure room, where what you call a dentist on hospital rotation can take care of the oral surgery resident, or an oral surgeon can take care of those things. So that is a negative air pressure room.
Yeah. Another thing,
Sure.
another question was, 1 minute, let me look at the chats. Another question is by Ria Gupta is, sir, I could not understand why should we apply alcohol-based sanitizer after hand washing with the soap? Can you explain again?
Yes. Okay. So normally, the use of alcohol-based hand sanitizers came in through the field of oral surgery and general surgery. After they do the hand scrub wash for the surgical, hand wash, to further purify your skin, they would apply the alcohol spray or alcohol gel, to kill any other resident organisms without the hindrance of dirt. You see, that is to go one additional step. That was normally done by surgeons who were constantly, doing long procedures, 4 hours, 10 hours, 12 hours, 18-hour procedures. They would rotate and then they would do that. And also in between, if somebody could fill in, they would still go ahead and do another hand wash, apply the alcohol gel or alcohol sprays, and then get back onto the patient again. So it is to further purify your hands. It is alcohol sprays by itself or gels by itself without hand washing is not very good. That's why I tell people, if you're going to use in a camp situation where you don't have a hand wash available, you can apply more of that thing and wipe it out with a paper towel. That way you're getting rid of the dirt and you're kind of purifying your hand.
Okay, the next question, Raghu, you got to be a little faster because we have a couple of questions here.
Sure.
Somebody asked that for how many days N95 can be used, or how often to discard, and whether we can reuse it or use ultraviolet to disinfect it. I think this is quite a common question, and also, but can you quickly just tell it quickly?
Yeah. So technically, these N95 masks were supposed to be used on one patient and then discarded. But when there was a glut in the supply of these, the FDA said you can use it for a day or 2 days. Then all of a sudden, some people said, oh, we can start decontaminating the mask by putting it under ultraviolet light. Please understand that ultraviolet light causes shrinkage. It does cause shrinkage in composites. Basically, these fibers are all made of plastic materials.
So it has got a layer inside. Yeah, that's right.
Correct. And that thing shrinks.
Yeah.
So according to one of the groups I'm a member of, Association for the Advancement of Medical Instrumentations, they have excellent scientists who actually do the procedures and then dictate to the FDA and the EPA and other people and the CDC as to how to reprocess items. What they found was none of these, either putting it into a steam sterilizer or into dry heat or ultraviolet light, were effective as far as the material composition was concerned. They may kill germs, but what if you killed all the germs, but then the air is going through very easily? It's of no use. So technically, you can use it for a day, 2 days, and then discard it. Go for another one. That's the best I can say.
I know, they initially, when it came up, they said that what you can do, you can have a couple of bags and you use it, put it in the bag, and then allow it to kind of stay for a couple of days, and then you can use it again, so that you can use it on multiple times also. That was initially when there was
right. They said you can put it out in sunlight in the plastic bag.
And you said it's a it's a lipophilic kind of a virus.
Correct. It dies. Yeah, it dies.
And I think it's very labile, and all it needs a little CS. So that's it. Okay. And another question is, you mentioned about PCMX soap, and somebody said that which is better,
Dettol.
PCMX soap or a chlorhexidine soap, and why? You said PCMX soap is quite good.
Yes, PCMX is good. I mean, I would go with chlorhexidine as number one. Given chlorhexidine is not available in certain parts of the world, PCMX is available in plenty, like Dettol-based soap. But try and buy the liquid-based Dettol soap. That is good for hand wash, and that's not expensive actually compared to PCMX, compared to chlorhexidine. Yeah. And it's available in India,
that's
abundant.
Right. Okay. So another question is, somebody asked me, what is about double masking? What's your opinion about double masking?
Double masking is as good as single masking, in my opinion. It's just like, remember when HIV was there, Mahesh, everybody used to double gloves.
Double gloves.
Yeah, but that was useless, actually.
Okay.
So I would just go with one mask and then and pray.
And remember, Raghu, last time when you started your lecture, I was also slightly intrigued by PAPR, positive air pressure aspirator, because those are not very easily available here. And I have our Professor Vidyarathan from TPGI. He's asking, tell more about PAPR, and he also wants to know whether it filters outgoing air, because what you are breathing out is it filtering out, and so because you gave me a number. I spoke to that Partha Sarthi in Bangalore, and
correct.
So can you just a little bit, because this is quite interesting, not available in the country, and I think this could be a good thing. PAPR.
Yes.
Can you just say about this? Yeah.
Yes. So PAPRs are positive air pressure respirators. What they are devices which actually seal it. It's like a helmet. It covers the head. It covers the front of the face with a face shield, and it hugs around your neck. Okay. So the air inside is sealed. Now the air from outside is pumped in through a HEPA filter. It has a pump. It has got a battery pack and a pump. And these devices normally weigh around 1 kilo to 3 kilos, depending on whether it's industrial, medical, or so on. What it does is it does not allow any of these contaminants like COVID, and it drops it down by 99.9%. The amount of these particulate matter, which are less than 0.3 microns in diameter. Those things are normally quite expensive. The two companies that make in the US are 3M and GM, like General Motors. And those run anywhere between $2,200 US to $2,800 US if you buy in bulk for the hospitals. In India, at least in Bangalore, as I was saying, there is a group of very nice innovators who have come up with a device, one for the medical prototype and one for the general public prototype. The medical prototype is about 300 grams in weight. It's built into a helmet, like a cricket helmet, with a face shield and all the good stuff. And the battery pack is within the helmet. There are no tubes coming out. And it does the air filtration exactly like the other ones, like 3M or the GM PAPRs. The one for the common public they have is one step down. It's exactly the same thing. The only difference is the amount of air. Instead of it being 76 plus liters per minute, it has around 70 liters per minute. And that is available for about $100 equivalent, and that can be used, as long as people can get, the clearance, at least as an emergency device. So these devices are very good. They don't fog up inside. They keep the air dry, and it can be used indoors or outdoors. It doesn't matter. I mean, think of Bangalore and Delhi, Mahesh. Even the police guys who are outside, 8 to 10 hours a day, even the particulate matter, they'll have better breathing with that. Now, if the same thing for emergency utilization is applied for medical purposes, we have a good enough solution, which is at least 10 times better or 100 times better than the N95 masks. And the filters are also very inexpensive. The ones the prototypes which they have in Bangalore, they cost $1 for a filter, and that can be replaced every day, or it can be washed in alcohol, they say. But I don't prefer, reprocessing those things, So yeah, you follow up with them. I mean, I've seen the device in Massachusetts. They have one copy out here in Massachusetts and one in in India. I think there are two in India.
They look very fancy. I also feel that there is a issue of wearing them, because they are quite quite a size, and sometimes I don't know the convenience of wearing them all the time. So that also
no. These are designed to be very light. They are they're not bulky either.
They look bulky.
I mean, all PAPRs are bulky. I mean, they look bulky. The reason why they make them look bulky is because people use loops, like surgeons use loops, dentists use loops now. There has to be an adequate amount of space in between.
Space around, that's
right. Plus,
right.
the air inside, there is a specification which the FDA and the CE people say that it has to have a certain size of a chamber in cubic footage so that the air can circulate freely. So that's the reason why it's a little bulkier. It is smaller than a cricket helmet, actually, if you look at it.
So thank you, Raghu. I think we had a good session today, and just a little bit of carry home message. So what you talked about today, I think we primarily talked about cross contamination and germicides. And as you said in the beginning, that every country has its own system, like India has an India FDA system where these devices and these chemicals are approved. And basically, we got to distinguish the chemicals germicides which come in contact with human beings and which are not coming in contact with human beings, that is bringing about coming in contact with the environment. So that can also be an issue with the environment hazard. So that's another thing. And you said that the immersion sterilants and are high-level disinfectants because they can kill spores. And surface disinfectants do not come under, they don't come in contact with human beings. And that's why you said, you said in the end that please avoid using surface barriers, rather rely on surface disinfectant, because barriers are also in a way adding to the waste and also to the cost and to the bulk and so many things. And you also said that quarterly ammonium compound, which have got a low alcohol, they have low alcohol and not a great surface disinfectant. Yeah. So you also said that hands are already clean, so use alcohol base to make them cleaner, all patients are given pre-procedural mouthwash, which the general practice, and we can use anything, but chlorhexidine is better, but people have tried other things also. You also said that what is really important is that when we use these sterilants like glutaraldehyde, firstly, the instruments need to be cleaned before they are immersed, and then we have to immerse it for long hours, 6 to 8 hours, sometimes 10 hours, depending on the temperature. So usually what is normally done is people just have it a holy dip. They put it there and take it out and use it. So
Right.
that's very important. I have, gone wrong initially, and that's how you learn from your. And then you said, you also said that the water-based cleaners are better. Water-based cleaners
Correct.
are better.
Correct.
And you said another thing is that when you disinfect, when you're using a spray, the most important thing is 2 steps. First step is just sanitizing it, rub it, clean it a couple of times, and then spray it and leave it for few hours, few minutes, in fact, because then only
Yep.
the contact comes, and that's how it brings about disinfection. And for an impression, which is very common, all the dental impression, we must wait for the TB kill time, and every chemical will have a different TB kill time. We got to wait, not just spray and pour it up
Wipe it
again.
off.
So that's another thing. And you also said the decontamination of suction lines at least once a week, which sometimes we
Correct.
don't do for months. So that's very important. You said wash your hands after taking off gloves, because by the time in just 45 minutes or half an hour session, so much of microbes have really multiplied, so they need to be removed. And you also said that N95, we need to have a face fit. I don't know how to get the face fit here in India. We don't have that system. And when we have a big clinics, big nursing homes, or a multi-specialty dental clinics, I think our HVAC system, that air conditioning system should have filters and lights and, all those mechanisms, so
Correct.
that air circulation per hour is changed. And, there is a change. I think about 6 to 8 changes per hour is what is desired that should be done. And the best thing what you said was, if you are wearing an N95 and if you are breathing through easily, that means it's not doing a good job.
Correct.
So there is
That's true.
there is some leakage, or you need a fit test, or you need to ensure that you put your mask together. And finally, as most of us are going towards digital dentistry, we also need to ensure that the mouse of the computer and the keyboard, they need silicone lining, so that we can disinfect them with chemicals, and so that we ensure disinfection. So thank you, Raghu, for a wonderful
And
second session. And I'm sure all of our delegates who are connected for the program are well stimulated, and they have now understood, and they are eagerly waiting for the next module, which is going to be held next week, next Sunday at the same time, 6 o'clock. Thank you.
sure, Mahesh, before we close out,
Yeah.
I take this opportunity, using this podium. What I have found with most of the regulatory bodies in India, when I was talking to some of my friends who have served on the regulatory bodies in the medical field, they felt that there was very little dental involvement to serve in those fields. Since you're based out of New Delhi area, I mean, try and see whether you can, just like how the ADA has got a technical advisory group which partakes with the FDA. Same way, I think, it's a good time for you leaders to form a group, an advisory group. I mean, not a regulatory group, but an advisory group to the regulators on our devices we use in dentistry.
No, I want to tell you that, Raghu, many of
You have
us,
served. Yeah.
many of
You
us are part of the CDSCO, which is a Central Drug
okay.
Control and organization. And
Very
I
good.
was on some of the committees, and they do have experts. In every committee, they do have experts from all over the country. So they do follow whenever such new device comes or registered or before they give approval. Now, all these vaccines, when they are coming for emergency approval, they have a team of experts who go through the data and the background, and then only it is approved. So there is a think tank.
India has that, Mahesh, and you are a part of that group. But what I'm saying is, you got to stimulate all the other dental scientists to get involved more. We have about 400 or 500 members in the US, but in India we have a much bigger dental group. We should have at least 100 experts in different fields of dentistry who should actually be actively involved. I know that you have 3 or 4 clones, one at the same time. I'll find you in Maids, same time in Indraprastha, similar to that.
Raghu, the best thing has happened in the last couple of years, and especially COVID. It has really awakened everybody, and everybody is so concerned about disinfection, infection control, and cross-infection and cross-contamination. I think really, this is the best. This is the better part of COVID. Of course, COVID has given us so much misery, but COVID also has given us so much goodness.
Positive.
You started thinking about our own health, safety of our patient, ourselves, more these things which we never cared. We always took it for granted. So, and also, I must appreciate, individuals like you who have over the years have come back again and again and used multiple forums to educate and also disseminate a very crucial information, because it is a common understanding today that when an impression is taken, it needs to be disinfected, which was not there maybe a couple of
when we were.
So every little effort makes a difference, and I also must salute you at this occasion that you have contributed a lot in this direction, and I think so much more needs to be done. And we have all our senior colleagues connected here. They in their own way, in their own avatars, in their own efforts and efforts, they will also propagate and disseminate this information, which is so vital in today's time. So
thank you.
Anybody else want to say something before we close? Arpit, we didn't allow you to talk anything last time also. Arpit, you want to say something?
No, sir. I think you have summed it up very well, and I don't think anything more to say at this point in time. All I have to say is welcome you for the next session, which will be there on the.
So you were displaying some code. You were displaying for code for the certificate today. You displayed.
Yes, sir. Yeah, the code is ICD. Those who have missed the code for the certification purpose, the link is there in the chat box on both the YouTube as well as the Zoom application. So please feed in the code ICD, and the link will be disabled in the next 5 minutes. So please hurry up. So we don't want proxies to be there.
Yeah.
So
thank you. But we have just a quick information by Kumar Rajan. He said that there are guidelines by Ministry of Health and Family Welfare in all these regards. So there are guidelines. It's not that government is not doing anything or authorities are not doing. But also let me invite Yogesh. You want to say something, Yogesh? We didn't allow.
Can I speak something?
Yeah. Fine. It was a grand lecture. I have listened to him many times, and every time I listen to him, I find something new. Thank you.
Thank you.
Thank you, Dr. Virmani.
Arpit, about the feedback form you have prepared.
Arpit, all the you have a data of all those who have logged in, and
yes, sir.
Feedback form can be given, and it can have a different parts, like session 1, session 2, session 3, and including the topics and what do I have to say, and in general impression that can be sent to all the members, and feedback can be gathered, and that can be shared with Dr. Raghupathia as well as ICD head office and ICD section 6. So
I'll just take 30 seconds more to bring in one important point. We will be observing World No Tobacco Day tomorrow. That is 31st of May. And this is a call for everybody whosoever is listening to me right now. Please, whatever possible level, please do participate. Please do help in spreading this awareness and controlling this menace of tobacco. So it is a responsibility of each one of us as a healthcare professional. So I'm sorry for piggybacking on this opportunity, but it is an important point.
You know, I think most universities, most colleges, I think Sharad is also, Sharad and Rajiv from Dental Council, I think they're all observing that the WHO slogan this time is quit for
Commit to quit.
Commit to quit. Commit to quit.
They also have a pledge.
Plus
Pledge on.
the pledge also, no spitting pledge, that is also there. IDA has started no spitting pledge, so you can sign on to that pledge.
ICD is doing a massive awareness campaign in Chandigarh, Tri-City, where some big hoardings and some big communication material is being displayed.
I think we have displayed today itself on one of the rotary of the Chandigarh. Very busy rotary. The person has placed all the, I mean, the brochure, etc.
So thank you so much. Thank you. Thank you so much.
Thank you very much.
To be included in the newsletter and shared on the Facebook.
So can we wind up, or anybody else has to say something?
Thank you. Thank you.
I'll take 10 seconds, sir,
Thank
if
you.
permissible. If permissible.
Yes, Kumar, bataiye. You want to say something?
Yeah, sir, there is also a guideline apart from the additional guidelines in the context of the PPE in the present context of COVID. We also have a national guideline for infection prevention and control in healthcare facilities, which has been, I have shared the link also on this. But the only problem is, which I raised to the government also at that time, it doesn't cover dental in many things. So if at all we have a dental care setting also added as an annexure, this will be a complete document in itself. Thank you so much.
But Kumar, you would also agree that we have so many guidelines, but we have no time to read those guidelines. You know, I think when you listen, interact, and this thing, you know, a lot of information, you know, gets assimilated. So it's good, and you know, I think it's good that either we concise those guidelines and circulate to everybody, and you know, so that we sensitize them, you know, educate them also. So many a times, of course, during COVID time, we were very stickler about all these things. But I think again, we have taken. Yeah.
Yeah,
Yes,
you are absolutely right. Absolutely right. There were a lot of people who were very strictly following it, but later on they gave it up.
Yeah.
I hope they again follow. There should be some stricter rules to really keep a check onto it.
Guidelines to follow the guidelines.
So thank you. With little this lighter note, thank you so much again. I must thank everybody, all our valued regents and dignitaries who have connected, and all our delegates, and we look forward to seeing you again next Sunday at 6 o'clock on the same platform. Thank you very much.